那我们就接下来请大家欢迎 Emery.
All right. Well, we're going to dive into some different cases now. The next case is another aesthetic zone case, just a multi-unit. And this is, again, we're going to be extracting 7, 8, and 9. We're going to place implants, and we're going to do an immediate milled provisional. So I'm going to take you through this case. There's not going to be any lab work at all done except for the digital milling of the provisional. So these are the teeth, ortho blunting. They've become mobile, and we know they're going to come out. So first thing we do is take a CT with an X-clip and do an intraoral scan of the patient's present dentition. Now again, people are asking me, what to do as far as virtual teeth and when to use these. When I'm planning a case like this, I don't hardly need this 3D part of the CT at all, because I'm going to be using those STL files, or the intraoral scan. And if you look down at the bottom, what I was telling you before is I use these to look at emergence through the STLs, and these are the windows I really use to plan my implants. Okay? The emergence is done through here. So if I had a lot of artifact up here, I just remove it with the lasso tool and just take it out. So after I guide the implants into place, I've extracted the teeth, I've guided the implants into position, okay? And you can see down here on the screens we talked about, I put some scan bodies on the implants. And then I do an intraoral scan. And then I take the scan bodies off and I do another intraoral scan of the soft tissue. And that's so they can make a soft tissue model digitally. And then I put healing abutments in and pack in my horizontal bone into the defects. Now this patient has nice thick tissue and thick bone, so this is an ideal immediate case because I know it's not going to change a lot. It's not a super thin bone tissue profile. And now I give the patient Exparel. Exparel is a local anesthetic that lasts 2 to 3 days, okay? Because the next day, patient's going to leave with nothing, and then that night the lab's going to mill PMMA provisionals and deliver them to the doc, and the next day the doc delivers those, and he doesn't have to give the patient any local because we used Exparel. I don't know if this is available here, but what it is, it's a lyophilized Marcaine. They put Marcaine into an emulsion, and you have to put it in with a really large gauge instrument, and it's used in general surgery, plastic surgery, orthopedics all the time, and now it's being sold to dentists. That's great stuff. I use it a lot. So these are 3Shape. This is 3Shape software, and those are going to be very accurate. These are the impressions we took were like for a final. And you see they emerge through the occlusal surfaces. That's because I didn't want to do any bone grafting. So these are going to be screw retained. And you can see that's exactly where I planned them. And if I go back to my plan, you're going to see that I was limited by the buccal bone. But as long as I know they're restorable, and I talked to the restorative doc ahead of time, everybody's on the same page, we're going to get a nice result. And I'll show you. So here are the provisionals. This is the final. Here are the provisionals. They're delivered. He fills with some gutta perch and then he puts some composite over, and that's the way the patient leaves that day. And I think this is a fantastic way to go, rather than doing a bunch of messy chairside analog. So we're doing a lot more of this. And these are the final. These are titanium milled, and these are Emax crowns. And that's the day they're delivered. I think that's beautiful. You can see we haven't had a lot of soft tissue recession because it's a thick morphotype. So I was smart about the case that I picked. If that was a thin morphotype, you would have seen a connective tissue graft. All right? So I don't immediately load cases unless they are appropriate. Now, how'd I do? How accurate was I? I mean, it looked really nice restoratively, and that's really what matters, but I was under 2 degrees. This is the mean for all 3 of those. And look at those numbers. They're fantastic. And that's why it was so easy. So let's step it up a notch. This is a young woman who's hit by a bus, and she's lost a lot of her lower teeth where they were damaged. She's got a moderate smile, but it's a mandible that we're working on, so the margins aren't going to be in the aesthetic zone. Accuracy is a big deal because she's small. And something I point out to petite women is that it's really hard. They're harder to deal with. Why is that? Because all their parts are smaller. And the restorative components and the restorative materials have minimum thicknesses. So when you're dealing with dentition that's tinier and smaller, everything has to be more accurately placed. So when I see a petite woman, I know it's going to be tougher. She's going to need regeneration. So how'd she come in? Okay, she had bilateral subcondylar fractures, which I fixed. And she has tooth avulsions and fractured teeth. Okay, they're fractured. Now, you'd say, oh, those are goners. Am I going to take those teeth out? I'm not. Because if I take those teeth out, I'm going to lose more alveolar bone, and I'm going to lose soft tissue. So I'm going to try to retain every tooth, even though I know it's hopeless, for about 8 weeks. So let the soft tissues heal because they're all macerated and damaged. And if I take them out, I'm going to lose a ton of soft tissue. So let's take a look at some of these teeth in more detail. You can see the teeth. They're just sort of hanging there. The alveolus, you can't see. It's because it's so thin on the buccal. Tooth number, go back. This tooth is number 27 is fractured off at the apex. Now that's a problem because even if I do a pulpectomy on what's left of the occlusal part of the tooth, it's going to necrose and get infected. So I have to take that one out. But anything else, even though it's sitting on nothing, I'm going to maintain it for at least 8 weeks. So this is her at 8 weeks. The tissue's healed. This is all going to come off. And in the meantime, she got pulpectomies done on all the teeth that I'm going to be extracting so they don't get infected while she's healing. When I take the teeth out, I can do, I hope, a definitive graft. I might have to touch it up and add more. But I'm going to over bulk this graft. And you can see I put in a lot of material because I know about a lot of it's going to disappear. Now the tooth number 22, I didn't see the fracture, but this tooth, I've taken the other teeth out. This is an imaging guide. You can see the imaging guide that I had in the mouth when I took the CT. And the reason I can use it is because the X-clip wasn't in the way. I put the X-clip away from me. I could have put it on the patient's right side, but I didn't want to reach around it, so I put it on the left side. All right. And when I put these implants in, I'm going to have to take that tooth out. I was hoping we could save it, but you can see there's a defect around it now, and it's going to have to come out. So this is the plan with the imaging guide in place. I can see everything, all the detail I need here. And I really like the imaging guides in cases like that. Now, why didn't I take an intraoral scan of the patient's teeth? I did. And the only one that shows up was the tooth number 22. I didn't do it before I took the teeth out because they were in the wrong occlusion. All right? I was not using those teeth for occlusion. I was using those teeth to maintain what little alveolar bone she had and the soft tissue so I wouldn't lose them. So when I put her implants in, I know I need further augmentation, so I'm going to, all the hot stuff now is, PRF and bone, particulate grafts. So when the implants go in, she's going to get veneer grafts to thicken things up even more. And then I've taken this tooth out, and I used the STL file for my planning for that tooth. And there you go. You can see the tooth was used for planning, and all the implants were placed. Now this is you're going to get two different videos here. The video on your left is the video of the screen, and you're going to see me do a system check with it. And then after I show you the system check, I'm going to show you some images with the Moravision, the 3D microscope, because you get some really nice, it's really great for planning. So here we are. I'm going to go ahead and I'm aiming the microscope, I'm doing a system check, and now you're going to see it over here on the right. You see I've done the system check, and now I'm going to start drilling. All right. And now I'm going to deliver the implant. And again, this is all under guidance. And you can see the bone in the buckle there. And then what I did is I put scan bodies on. And then I scan the patient. And we're going to get PMMA milled provisionals. Now, one of the problems with this implant company is the stroma and the variobase. They're not tall enough for really long provisionals. So what we did was we milled titanium cylinders to make temporary abutments. And these, again, she got Exparel. And then actually 2 days later, she got these delivered because these took a little longer to make. And if we look at the prosthetics, you can see this is going to be easy to restore. Okay? That's what we want. And that kind of accuracy in thin ridges like that is critical. You can't do this freehand unless you make big flaps. And do you want to lay a big flap on a particulate graft like that? You don't, because you're going to lose more of it. So these are the temporary cylinders that were milled. And I'm going to need to do, later I'm going to do a little soft tissue graft there. And that was allowed to mature. And then he's taking impressions now of the mature tissue. And you can see he's using that technique I showed you before with the running the Duralon into the soft tissue to capture the profiles that he's developed with the temps. And these are the final custom gold UCLA abutments in place with an altered cast with a soft tissue cast. And then what we're doing here is picking up the framework. And this is as far as we are. He actually sent me these pictures last night, these two pictures. So now we're waiting for the final. But those are pictures with the temps in place. So you can see where we're going with this digital approach. Now, why aren't we making the provisionals ahead of time? Well, we're not, because you can't get them that accurate. You can reline them. You could make them ahead of time and then reline them, but you'd have to reline your provisionals. This way, you don't have to reline them. You just screw them in, and it's going to be very accurate. So you were asking me before about artifact. Look at this patient. You think there's going to be some artifact on that CT? Okay, this is a gentleman. He's 90 years old. He's got a mild dementia, so removable is no good for him. Obviously, he doesn't have a problem with money. I didn't put all those implants in. One of my colleagues did. And this bridge up front is failing. And if you ask the prosthodontist, he said, I made a mistake. I didn't think the guy was going to live that long. I should have put implants up front. And he got recurrent decay. The guy's a Bruxer. So this is the way it looks when he came in to see me. you say, well, look at what he's done to this, but he didn't want any of it redone because he's 90 years old. He just wants to chew, but he can't handle, because his hands don't work very well. The idea of a removable is just not anything he wants to do. So let's look at the CT. This is what you were talking about. How do you plan in that? You can see a little bit of it, okay? But you really want a treatment plan with that? No, you don't. Now look at with the STL file superimposed there. And you can turn on and off the opposing arch. When you're planning now, you could just take a lasso and get rid of the entire DICOM file and just plan with the emergence through here and these 2D views, which is what I do quite often. Now, if you lasso something and you cut it away, you can put it back with the negative lasso. And so anything you remove from the CT, you can put it back. If you wanted to just remove this flash here, you just go around it with the lasso and click it and it'll disappear. I don't know if any of you used the old Implant software where you had to segment the images and how much time that used to take. It drove me crazy. I hated doing that. With this, you don't need to do any of that. It takes seconds to do it. So let's talk about bone reduction and extracting teeth when you're doing implants. Now, when you're using a static guide, and these are all coming out, you can't use a static guide with the teeth in there, can you? You have to remove all the teeth. Now, let's say you didn't have an intraoral scanner, and you took an impression on this guy, and you sent it off to get your static guide made. You took all the teeth out, and it didn't fit. Where are you now? You're freehand, aren't you? Well, with dynamic guidance, you don't need to take all the teeth out. You can take out a couple of teeth and use that tooth and that tooth to do your system checks. And you look at the soft tissue. I'm not really hardly touching the soft tissue. Sometimes when you put a static guide on, the soft tissue gets in the way, doesn't it? So you don't need to do anything you used to do when you were completely freehand with a dynamic navigation. You can go one tooth at a time if you want to. Okay? So you got to remember that many of the things you did with static guides you were forced to do by their system. When we get to the bone reduction guide, I'm going to make that a little more obvious. Now, this is an unedited use of the densiburs. And the reason I say it's unedited because it takes a couple minutes. Now, I'm going to put in an implant on a 90-year-old guy. These are going to be loaded, and he's abrupt.
Show me measuring the densibur. I just measured it. Now I'm going to put it on reverse.
So you run these burrs in reverse when you want to densify.
Check. Slide it up a little bit.
We're doing a system check, and we're adjusting the clip.
More.
You can see my staff is touching it down there.
System check. Now show the position up here.
So I'm looking up here. Now I'm drilling. You have to pump these things. You pump them, you're running in reverse, and you're not removing any bone, you're compressing the bone. So when you want to do immediate cases, you want good torque, and you don't want to waste bone. So this is a fantastic way to do extraction immediate.
Compressing it. This is an immediate extraction.
I'm really densifying this, so I'm pumping this bone. Got a little Mozart in the background.
You all right? You need to rest?
Oh.
All right. Any bothers, you just
I'm not putting a 90-year-old to sleep.
Now it's almost ideal. Slow down. Okay, perfect. That's good.
So you can see, I just did that osteotomy pretty quickly, just like we did on the sawbones. And He goes to his restorative doctor to get the provisional made, and this is just an analog. He's going to pick it up because we want to do it that day. Now, those look like they're crazy angles, and this is where I say you got to believe in your plan, because I might not have put those implants where they look, but wait till you see the final outcome. And this is his provisional. You can see he's a Bruxer, square profile. And he's 90 years old, and he got immediate provisional. And you don't think that's loaded? That's loaded. Even though he takes it out of occlusion. He doesn't really follow instructions. So, how did I do as far as, this is the mean for 5 implants. Okay, under 2 degrees, 0.9, or 0.8 and 0.9. 800 microns and 900 microns. That's excellent. Now, if I put those in, and that plan was good, those restorations are going to be gorgeous, even though they didn't look right when you look at them with parallax. And that's why I say you got to believe your plan. So let's see how we did. There you go. That's a prosthodontist's dream. All those implants are coming out in beautiful space. They're far enough apart. So it makes the restorative really easy. So this is him at 1 year follow-up. Oop, it jumped fast. So this is him at 1 year follow-up. And he's a happy guy. He's got his oxygen on anyway. So let's look at some new concepts. Now the reason I could do that case on him immediately is because I densified the bone. Now I'm going to show you something that's really, when I say this is really on the cutting edge, it is. Root shields, there are different names for this. Socket shields, root membranes, partial root extractions. And there is literature behind it. This concept started to come out into the literature in about 2010. There's a group of periodontists that are doing this. But it also corresponds with what's going on in oral surgery with third molars. In third molars now, we're leaving roots behind intentionally when we take out wisdom teeth, if we think we're going to damage the roots, the nerve. More evidence. They're using it to maintain ridges. And this is the article that really caught my eye. And this is a 5-year follow-up on a number of patients who've had these things done. And when I saw this a few years ago, I started trying to do it, but this wasn't guided. And what I would do is I have a patient who I was going to extract a tooth on, but before I'd extract it, I'd try to do the socket shield. And I knew I was going to take it out, and I couldn't do it. I wasn't good enough to do it. And then comes around with dynamic navigation. So what are we going to do here? We're going to take this tooth and we're going to just leave the buccal part of the root. All right? Now, why do we do that? The blood supply for this buccal bone comes from the periodontal ligament. So when you take this, if you take the entire root out, you've torn the blood supply to all the bundle bone. The bundle bone is the bone that the Purkinje fibers insert into that hold the periodontal ligament. So if you don't take the buccal root out, and you don't touch the blood supply, so you don't lose any bone. It's an interesting concept. Does it work? Now there's human histology that shows bone grows between that root and the implant. You get osteointegration against it. Now this comes out of some endogain literature, and they're saying you need to put endogain in, but that's not what people are doing. They're just putting in a xenograft there. So this is the first case I did, okay? So it's a high smile failing case. You don't want to touch any of the margins of these because you're going to see a lot of metal. This is a pretty hard case. Now if I was doing this, I'd have to do a connective tissue graft, okay? And so this actually saves your patient money because they don't have to have any regenerative procedures done. So this is a cantilever off 7, is cantilever off a 6. Now, the endodontist doesn't use an X guide, so they said this tooth is hopeless. Well, I would tell you now that you could use the X guide to go through there, even that it's an off-label use. So there we are beforehand. Now, how do I do this? I take a CBCT with an X-clip. I do an intraoral scan. You have to use a scanner to do this because you need fine detail. I evaluate the soft tissues around the root. You have to have a periodontally healthy root along the margins. You can't have any pockets or anything on the buccal. And you want to look at the pathology at the apex. You can have pathology at the apex, and we'll talk about that. So what I do is I plan the ideal implant, and then I plan for the excision of the apex. I plan an implant straight down the canal system right to the apex, because then I'm going to obliterate the apex. You have to take out the apical portion of the tooth. And then I plan, there's the ideal implant, and you can see this is used to go right to the apex. I'm going to destroy the apex. There's your implant, and you can see there's the soft tissue margin, so it's 3 millimeters from there. So I planned everything in great detail. I start with a Lindemann burr. This is a dentatus drill. It's a long, skinny drill, and I use that as a probe to see where my lateral cuts go, so I don't cut through the periodontal ligament space laterally. And then I use this long, round burr to obliterate the apex, and these are used to plasty the remaining root and the top of the root. You want to take 1 millimeter off, so your remaining root is 1 millimeter below the soft tissue margin. There's my osteotomy down the implant right to the apex. And if you're right against the buccal plate, it's okay. You can feel it with your finger. It's interesting to see. You'll see how accurate this system is. And you can see how I'm cutting. There's the virtual tooth. Now I've gone to the apex, and then I split it laterally with a straight 701. And I'm going to use this to feel inside there and look and make sure I haven't cut through into the adjacent teeth. Here you go. Now you can see, if you look at this 2D view, I'm out laterally. You see there's not a lot of space, and I can make sure that I've obliterated the apex, but I haven't gone into the adjacent teeth. And this is what I'm left with. And then I'm going to plasty that down. I like to use the microscope to do it. I'm going to plasty that down. Okay? And then I'm going to put in my implant. You see I've gone, this is 3 millimeters there. I've taken off 1 millimeter all the way around there. And I smooth it off with this chamfer burr. So there I've placed my implant, and I've done a buccal graft into that area. And then I'm going to cover it up with some periacryl and put the provisional on. So this is the day of the surgery when the patient leaves. So this is the patient at 8 weeks post-op. I don't have a picture of the final. I got to get the patient back in. They haven't come back. But you can see it. I haven't lost any soft tissue. So I'm going to go a little quicker through the next case. But the big thing to notice about this case, and I throw this in because I've done a lot of these now, to show you the only complication that I've had. Okay? And what's the complication we talk about? Well, the root, a little piece of a root will come up. It doesn't come up, the soft tissue recedes. In this case, because there was so much inflammation around this old crown. And I'm also going to show you what you can do with pathology at the apex. So this is a high smile, adjacent restorations you don't want to touch. She doesn't have the money to fix this. It'd be nice to go ahead and adjust the margins, but we're going to try to keep everything where it is or improve it. And we have a poor prognosis of number 8 and 9. She had had an apical of number 8, so this is all coming from this tooth. And there's not enough to put an implant in here. This tooth is a pontic cantilevered off number 6, so we're going to leave that alone. Now, why did this tooth fracture? This is proclined a bit, and that tooth caused fracture of that. So that bottom tooth has to be addressed. So let's look at the x-ray. This is the apical that's on this tooth. But all this tissue is burned out a little bit on this periapical. When I probe in here, I can feel the bone, but look at the inflammation here around this. It's got a little bit of a pseudo pocket. It probes around 3.5, 4 millimeters. So that's my plan for number 7. You can see there's not enough bone. There's good bone volume in number 8, but there's all that pathology at the apex, and I'm going to have to get rid of that. And when I probe the buccal, it's solid bone. So there's my final plan for number 8. And there's my plan for the obliteration of the apex. I've got to get rid of all this stuff. So it's straight up the root. And you can see there's 2 different plans, one for the implant and one for the obliteration of the apex. So this is plan for number 9. We're going to take that out, and we're going to do the same thing in number 9. There's my plan for the excision of the apex at number 9. Here's my removable provisional. We're not going to load this case. And I like in these cases to have a provisional that's removable if I can, because I never know whether I'm going to actually be able to do this. What is the one thing that causes you to abandon this? And that's if this is mobile. If you do all that and that becomes mobile, you just got to take it out. You can't, any root fragment that you leave cannot be mobile. Now you can see the inflammation here. I haven't done anything up there. So this one's finished, and now I'm going to do this one. Now when I say it's finished, I split it, and then I went up there and irrigated, and I took all that amalgam out of there. And I used a round burr to break it apart and get it out of there. And I can do it all under guidance because I can see it with the scanner. And then I'm splitting the other tooth. And there are the implants with the bone graft. And the tissue's angry looking, but it was angry to start with. So here are the implants. This is the post-op x-ray, and you can actually, it's a little hard to see, but I actually measured out how much of the root I left behind. So there you go, immediate post-op. And this is the patient 2 months later. That's a big difference. Now, I always put my implants 3 to 4 millimeters deep, and those are 4 millimeter gingival healing cuffs. But what's going on right there? There's a little bit of a root sticking up there. So what do I do about it? I take a diamond, and I just mow it down. And this is the final restorations. And you can actually see a little bit of the root right here. If it ever came up, I just take a diamond and take it down. And that's really the only thing you can look for, that you, as far as shown up in the literature. That's pretty nice compared to where she started. So there's where she started. And this is where she ended up. Now this is tilted up a little bit in this photograph. But you can see I didn't lose any tissue on this lady. If anything, we gained it, and it's certainly much healthier. So here's another patient. We're going to take out a premolar. He's a bruxer. You can see the tooth's fractured. I'm going to go through this a little quicker. So I plan my ideal implant position. And this is post-op, and you can see the little bit of the root there. And I did a sinus elevation with densiburs. Here is the patient, 4 months, when I'm doing a torque test. And again, 3 to 4 millimeters. This is a 4 millimeter high. I haven't lost any tissue at all. And here's the final restoration. If anything, this implant looks better than the natural tooth. He's got recession here, and he's got none there. So this, I think, is a big deal. And I can tell you the people in, Salama, Garber, a lot of people are talking about this. But it is really hard to do if you're not guiding. I couldn't do it. I wasn't good enough to figure those angles out. And I think I'm a pretty good surgeon. But with this, it doesn't take me long. I planned for one of these for about 60 minutes versus an implant, 45 minutes. Because I have to plasty the root. And that takes me a little longer. And I use a microscope to do it. But, I've lost no bone here. It's amazing. Now they're starting to do the same thing with the mesial contacts. all right, and the distal contacts. So they're making C-shaped ones. So how about the posterior maxilla, a new concept? This is osseodensification. This is a huge deal. And you can't do this with a static guide. Now, these are their images from their website, and you can see they take serial x-rays. And what they're doing is running a drill in reverse and pushing bone up. And this works. Now, how do we do it under guidance? We don't need serial x-rays. What we do is I plan a normal implant for the length I want, and then with my initial burr, I go up to just short of the sinus floor and I stop. Now, before I pointed out to you that striped line on the depth, it shows you your maximum depth. So you drill to there and you stop, and you got to look while you're doing at this, any of these two windows, and when you get there, it'll put that line and you stop. And then you start putting larger and larger burrs until you get to the 3 millimeter burr, because that's the burr you use to perforate into the sinus. Now, if you're only getting 1 or 2 millimeters of elevation, you don't need to put any graft in, because all the bone, when you're running in reverse, is grafted. None of it comes out. When you drill, when you drill into somebody and all the bone dust comes out, no bone dust comes out. It's an autograft. It gets compacted in, and at the apex, there's a shock wave that pushes it up. So you don't have to hit your patient with an osteotome. So again, you use that, you drill and drill and drill until you get to the 3 millimeter burr, and then you can go beyond it. You never want to put your burrs more than 3 millimeters past the floor. And when I start going up, I use Dynagraft, which is a flowable bone graft. Some other people will use cancellous bone and pack it in there. And I'm going to show you the literature on this in a moment. And you can get 4 to 8 millimeters of augmentation with this procedure. Predictably, I think you can get 4. That's in my hands. Now, this is a lateral augmentation that I did years ago, and this is a Densa-Burr sinus elevation right here, 2 implants next to each other. I'm going to show you some more. This is another one with a different kind of implant, and I'm measuring how much augmentation I got. And I'm taking this tooth out, and I actually measured 2 millimeters of bone here. I don't want to put in an implant. They'll tell you can 2 or 3 millimeters of bone, and you can generate 10. So what I did was I just grafted this, and then I augmented that, and it's about 9, 10 millimeters of bone. And then I'm going to go back and put in an implant and do some more. So let's look at some evidence. This is the only guided Densa-Burr data that there is in the literature. It's not published yet. I'm showing it to you before it's published. What we did was we mined our data from that large database. We had 201 patients that had posterior mandibular maxillary implants placed, 45 freehand, 197 guide, of which 34 of these were osseodensification. I did all those cases. So this is one surgeon that did these. Now this is freehand of the entire group that was posterior maxilla. That's posterior maxilla, guided posterior maxilla, and this is with osseodensification. And there is no statistical significant difference between the two, okay? So what it's telling you is in poor quality bone, where you're doing a sinus elevation and you're doing augmentation, with guidance you can be just as accurate in this crummy bone, and that's a big deal. So how much augmentation do we get? I got one of the residents to go and measure. We measured mesially, distally, buccal, lingually, and then the bone at the above it. We followed them for 6 months. We didn't lose any. And these are all the measures here. These are the means and the standard deviations. And you can see we're around 4 millimeters. The apex were around 1.5 and 2. Those are my cases. Let's look at somebody else's. This is Ziv Mora. They presented this data at their World Conference. They did 231 sinuses and 272 implants, and their residual mean bode was 5 and it went from 2 to 8.5. And you can see their augmentation was 3 to 13. They lost 7 implants, so it's no different. This works, okay? I can tell you this works. And you can't do it guided unless you use those open guides, unless you guide with dynamic navigation. So let's look at a bilateral posterior maxillary case, mandibular case. What do you do when you have implants on both sides? You can't put 2 X clips in. This is pretty straightforward. In the middle of the case, after you do one side, you recalibrate. Flip it over. That's all you do. And you saw me calibrate today. It takes about 30 seconds. And then you do the other side. And how'd I do? We did almost 1 degree, and then 500 microns, 700 microns, 1.6, 200 microns, and 39. So flipping it over doesn't affect it. So let's do a posterior mandible, a complex cases. And this is a case that's impossible with the static guide. This is a patient that had squamous cell carcinoma, and they had tibial bone graft, and they also took soft tissue with it, so the tissue is about 1 centimeter thick. Now the patient can't open wide enough to take an impression or put a static guide in, and you don't want to strip off all the soft tissue on this graft or you'll kill it. So this is a really hard case, and these tibias, as you know, are small. So what am I going to do for my treatment planning? I can't get an impression, so I'm going to take an intraoral scan. And then I'm going to use virtual teeth. So this is completely digital on one of the hardest cases you can possibly do. So there we are. I'm doing my virtual plan with my wax up. I use ideal size teeth, and there's my post-op. Now that would be impossible with a static guide and be harder than hell with freehand. You would never be able to do that. And these all integrated. So, where are we going next? Let's look at a complicated maxilla. All right? And this is where I'm going to show you what I showed you at the beginning. When do you use one of these full arch duplicate provisionals? You want to try to do this with an X clip because it's easier. So I have a failing full arch splint, and the patient has a bunch of implants. They're Bicon implants with peri-implantitis and no anti-rotational component. The prosthodontist says, I will not do a full arch reconstruction on this lady with those lousy implants in there. Accuracy is a big deal. When I show you where these implants are, I need help getting them out. And I'm going to do a big reconstruction. So this is the patient. This entire thing's failing. Those have been in for 20 years, and there's peri-implantitis all around them. You can see they're starting to look at it, and that's ridiculous. Nobody do this now anyway. So here's the full mouth X-rays. So this is what it looks like underneath that after that was removed. And the patient wants to stay fixed. We're never going to go removable on this case. I don't want to put removable on top of my bone grafts when I take those implants out, right? So how do we do this? How do you image this? Now remember what I told you about STL files. They're a surface, right? So how do you superimpose a surface on a volume? Because they're not going to match up. And look at these implants. They're in the patient's nose. Now if I drill through here with a trephine and go into the nose and hit the turbinates, it's going to be a mess. So how do we do this? What's your plan? So all these teeth are eventually going to be removed, so I'm going to do a serial case. I do a lot of these, where I take some implant teeth out, I use the teeth temporarily, and I'll do implant conversions. I go from you know, a few teeth and a few implants to different teeth. So here's my plan. We're going to fabricate a full arch provisional. We're going to duplicate it as an imaging guide. We're then going to bond the X-clip by just not lubricating it to that guide. We're going to extract 6 and 8 right here and 8. There's no implants there. And do immediates 4, 6, 7, and 8. And then we're going to wait. Then we're going to do an implant conversion. And then we're going to remove, on the same day, I'm going to put on those implants I placed an X-clip and take a CT. And then I'm going to remove these implants and bone graft. That's where we are now with this case. And then I'm going to do the same thing, put an X-clip on the other side, same day, do the plan, and place the last implants. So here we go. That's the day. We make the duplicates of the provisional, and you can see the barium's added in there. And then I put an X-clip on it, and I take my CT. So here's my X-ray with the full arch temp on it, and I plan the case through the imaging guide. Now I could take a CT, an intraoral scan of it, but this looks pretty good. I can easily plan with that. So there I am on the day of surgery. I cut the provisional off, and now I go ahead, take the teeth out, and I've taken the teeth out, and I've placed the implants. I'm going to do a big graft, right? You can see there's a membrane here, and I'll flip it over and then put some PRF over the whole thing. And there it's closed. Put the provisional back on. And there she is 4 months later. You got a little hyperplastic tissue underneath it. And there's my post-op X-ray. Take an LED laser, do a torque test. They're all integrated. Goes on over and gets implant conversion. Now these are going to be loaded. Okay? And I'm going to take a couple of teeth out in the distal, and then I'm going to take this out. Now, this is important. You see how the X-clip's yellow? What does that mean? The software in the X-guide will tell you if there's movement or there's any problems with the X-clip. Now, this is on the day I'm going to take out these implants. I put the X-clip on the abutments and the preps, and they don't have any undercuts on them. So that X-clip moved during the CT. Now, what will this matter? This shows us that there's between 300 and 500 microns when you see that, if it's yellow, of movement, or those ball bearings are out by 300 to 500. The software sees it. It doesn't matter because I can do system checks, right? It makes no difference. As long as I do system checks before I do anything, I'm not going to have a bad result. So here you can see I'm laying the flap and I'm releasing the flap. I'm going to be taking out all these implants and releasing the flap, doing a little bit of stretch in there. And now what am I doing? I'm doing system checks because I'm using a trephine to take the implants out. I'm removing the implants from the guidance, and I don't want to drill with that trephine up into the nose. Okay? So you saw me doing system check, and I do system check after system check. Why? Because I know there was 300 to 500 microns of movement in that X-clip. And then look at this. That was the implant in the nose. That's just a mucus retention cyst from the nose that came out with that implant. I obviously didn't chop into that mucus retention cyst. It's adhered to the implant. So I bone graft, and there's my post-op. All right. So this is where we are with this patient. The next time I'm going to do is I'm going to do what I've done before. I could make a duplicate provisional with imaging guide on here, take a CT, and then and then do the implants on the other side. Or I could just do it all on the same day with an intraoral scan. And you can see we got a nice bone augmentation. So let's look at a complex case by maxillary. We're going to do upper and lower. This is a gigantic case. I'm going to show you. This is done over a number of years. All these teeth are going to be lost. This is back in around 2014, 15, before the X guide I had it available. And this is an imaging guide that Progaman made to use with an anatomage. And you can see this is a dual scan technique. I was just showing the two different. This is with a imaging guide. This is with a denture with fiducials. So these implants were placed with a static guide, and these two implants were placed with a sinus elevation. You can see it's single stage. What happened was we lost those two distal implants because it was poor bone quality and they got loaded by the denture. So the acrylic provisional is made. And so then I do bilateral sinus lifts. Okay? Again, this was before I had the X guide. And now X guide's becoming available while these are maturing. And so the rest of these implants are going to be placed guided. But I have a fixed hybrid restoration on the maxilla. So there we go. There's an imaging guide. I'm going to cut the imaging guide away, and I'm going to put an X-clip on the provisionals. Now remember, I told you to lubricate the provisionals with topical. If you use Vaseline, it won't work. They'll bond. Use topical anesthetic, and I treat this like a dentate case. And I do sinus elevations and I densify that sinus graft with at this point with the VersaBurs. And there we go. Those integrated. So now I'm going to do the mandible. I don't like reaching around, so I put one on. I'm doing bilateral posterior and anterior. So when I do this implant here and that one, I use this X-clip. When I'm putting these two, and that one, I put this X-clip. There we go. The implants are in place. And now you're going to see some great prosthetics. These are the provisionals. Now this guy's go through perio, endo. Perio and ortho. We actually we align the 4 remaining teeth. Now why would you keep those teeth? One of the reasons we keep them is for proprioception. There's a lot of ceramics and crown and bridge on here, and if you can keep a few teeth, that'd be great because then you have vertical and you have proprioception. Some people might say that that introduces more risk because the teeth are the biggest problem in the long term. So what we're doing, he's again using the same technique. He's gotten the soft tissue contours with his temps. He's going to pick them up with the GC pattern resin inside these through the tray. He takes it through the tray. He puts what he does is he cuts a groove through this tray and puts wax in there, and then he just pushes all these right through the wax. He doesn't have to cut holes, and it all doesn't come ocean out. It's a great idea. So these are your custom abutments, and there's the framework. And then he's going to adjust. The patient said, I'd like to show some more tooth. And he says, I don't think you really want to do that, but I'll give you a shot. And so he put some acrylic, composite on here to play around with vertical. He's checking midlines. He's doing everything with the provisionals, and then he's going to go ahead and transfer it to the final impressions. And there we are with the final restorations. And this guy's a happy camper. So those are the final restorations. So questions so far?